Hi everyone, welcome to chapter 8. So this chapter is interesting. It's going to talk all about different medications for mental disorders. So we're going to talk about these different disorders, talk about how they work a little bit, and then how different medications can both be used to treat or help alleviate some of the symptoms with these mental disorders. So things like antidepressants or antipsychotics, we'll go through in detail and kind of talk about how, again, these interact with the body to help kind of alleviate some of these disorders. We will also talk at the end about a few different consequences too of these and just some general things to be aware of. So we're going to go through, we're going to do a couple things. We're going to talk about the classification of mental disorders. We're also going to talk about early treatment, how this was treated back in the day. Then we'll talk about some things like antipsychotics, some new medications that have been developed, antidepressants as well, mood stabilizers, and then also some consequences here of this pharmacotherapy, of this medical way of treating some of these mental disorders. All right, so when we're talking about classification of mental disorders, the big thing that really comes to mind, the big thing that we use and has been developed and used and adapted over time is the Diagnostic and Statistical Manual for Mental Disorders, the DSM, right? So you guys are probably familiar, you've probably heard this before. We're on the DSM-5, there is the version right now. And this was developed by the American Psychiatric Association and is generally a way to classify and diagnose and group different types of mental disorders. So most of the time, these terms, these definitions, things in this book become standard for all medical health professionals. It helps to keep everything kind of unified across the board. When we talk about mental disorders, there's a few different ones to talk about here. So of course, there are anxiety disorders. These tend to be characterized by excessive worry, fear, avoidance, things like that. And under the DSM-5, they tend to be classified as things like specific phobias, social anxiety disorder, panic disorder, agoraphobia, which is the fear of going outside or being in large groups, and then generalized anxiety disorder as well. We also have things like psychosis, right, which is a serious mental disorder, which involves basically the loss of the contact with reality, right? You aren't even able to really identify what's real and what's not real. Schizophrenia, which under the DSM-5 is classified really with symptoms of two or more of the following: either delusions, hallucinations, disorganized speech, disorganized behavior, or a lack of emotional response. And so again, these symptoms normally have to last for at least 6 months to be classified as schizophrenia. And also interfere with some form of social or work sort of functioning. So there's a pretty strict requirement here really to be classified as true schizophrenia from the DSM. But I think, we can discuss how that's important in really having clear distinctions in different disorders, or maybe how there's some room to, discuss where this line should be drawn. Then, of course, we have bipolar disorder and its related disorders. There's a few different forms of bipolar, but it tends to be characterized by either depressed or manic symptoms. And oftentimes people don't always fit really nice and neat into one of these categories. But the DSM-5 basically organizes these into either major depressive disorder, which is really only having depressive episodes. So no mania with major depressive disorder, just episodes of depression. And then there's bipolar 1 disorder, which is basically where at least one manic episode and possible alternating periods of depression sort of come into play. And then, of course, we have bipolar 2 as well, which is classified normally as having both manic and depressive episodes in that case. All right, so when we talk about mental disorders, one of the important things to talk about here is sort of early treatment, right? How was this treated and dealt with early on or back in the day, right? So one of the earlier forms of treatment, as crazy as this may sound, is actually malaria therapy. So this was introduced around 1917 to treat general paralysis. And this is basically from syphilis infection of the nervous system that causes psychosis. Kind of crazy to think about. But what they did is they would actually induce malaria, and the fever associated with the malaria was often thought to help improve this psychosis condition. This was eliminated basically once we discovered antibiotics that could cure syphilis, and we no longer needed these more severe forms of treatment. We also have narcosis therapy, which was around the 1920s, where depressants were used to actually induce sleep for a week or more to try and treat some of these mental disorders. Again, efficacy, not the best. We have much better ways now, though this was one of the early treatment methods. Then, of course, we have this idea of thiopentanol sodium, or this truth serum, which was used during psychotherapy to actually help patients express repressed thoughts. So the thought here was that using this to help basically reduce their inhibitions, be more likely to actually say what they, actually were thinking and tell the truth, so to speak, would actually help them treat these mental disorders to try and just actually access and get off their mind what was going on. There's also insulin therapy, which was used early on to treat schizophrenia, where basically repeated treatments were tended to be problematic as patients became basically agitated after a few minutes, and the drug tended to be administered before the seizures began. And so, this wasn't super helpful, but it was used early on, again, to try and treat schizophrenia, but again, had issues with seizures and things like that. We also have electroconvulsive therapy, or ECT. So this early on was used to treat schizophrenia, but really showed no long-term benefits. So it's still used to treat severe depression when patients don't respond to medication. So this is sort of a very severe depression treatment that is still used today. And we'll talk a little bit more about this here in a minute when we get to that. So when we talk about antipsychotics next, there's a few different ones we can talk about here. Medications to help treat psychosis, right? So early on, we had these penothiazines, which was an early group of drug used to treat psychosis. And then they kind of became known more as tranquilizers, right, or neuroleptic drugs. And now we basically call them antipsychotics. So the name is kind of adapted over time in what we actually kind of refer to these as. But when we talk about these and we talk about the mechanisms of action here, we think about this in two different ways. So we have what are known as typical antipsychotics and then atypical antipsychotics. And they work under two different mechanisms of action. So typical antipsychotics, basically, they respond to the nervous system they give the nervous system repeated administration of this dopamine antagonist, right? So what they do is that means they block those dopamine receptors, specifically the D2 dopamine receptors. So again, they're blocking those dopamine receptors. So there's less ability for that dopamine to be binding and sending that signal. Some of the downsides of this, though, is it actually often would produce pseudo-Parkinsonism, so effects similar to Parkinson's disease, where you'd get sort of these tremors and things like that. Then we have atypical antipsychotics, which are basically referred to as serotonin dopamine antagonists. So not just dopamine, but also they block both the dopamine and the serotonin receptors. And these tended to produce less of those pseudo-Parkinsonism, so less things like tremors and issues related to these medications. And so now most of what we use are atypical antipsychotics, so ones that act on both dopamine and serotonin agents. So some of the advantages here of these specific, antipsychotics is that they tend to not produce drug dependence. They have relatively small side effects, though some can include things like allergic reactions or even photosensitivity. And one of the more serious ones, depending on the person, could be actually they might lower the white blood cell count in people. And then, of course, some do still produce that pseudo-Parkinsonism syndrome. So tremors of the hands, maybe some muscular rigidity or things like that. But overall, still some advantages here. And the side effects that I just mentioned here as well, like those reactions and photosensitivity and pseudoparkinsonism. We talk about their effectiveness here. We also can talk about sort of the long-term effectiveness that kind of counteracts the short-term effectiveness. So oftentimes, short-term, we might see positive effects. It might be relatively good at treating some of these psychotic episodes, but long-term, we actually see pretty bad, not great effects of these medications. Oftentimes, it is due to participants just stopping the treatment or stopping the use of these medications. So in one study done, they found that about 3/4 of patients actually discontinued the use of their antipsychotics by 18 months of treatment. So they may have, made it a year and a half or so, but at that point, they decided to discontinue and not keep taking them. So there's really no clear evidence whether or not these atypical antipsychotics, most of what's used today, whether or not those work better than conventional drugs at treating these psychotic symptoms. And so it's definitely unfortunate in that regard. We're still making progress, but we have not really unlocked this yet or solved really this problem. And we have some different sort of factors here as well when looking at both children and elderly. So children tend to have, more risk of things like weight gain or metabolic changes, oftentimes more obesity, diabetes, and even some cardiovascular problems. Whereas for elderly patients that take these medications, normally they have increased risk of death from just like cardiovascular issues and things like that. So definitely still some issues here with this type of medication. We're talking about antidepressants specifically. There's a few different ones we can talk about as well. So we have monoamine oxidase inhibitors, or MAOIs. These tend to elevate mood. They increase the availability of serotonin, norepinephrine, and dopamine by inhibiting their breakdown, basically. So they don't get broken down through those enzymes and put back into the bloodstream. They kind of stay and hang around longer because we're inhibiting the ability for them to get broken down. So again, some of the downsides here, though, is that it can alter that normal metabolism because we're affecting those enzymes that would break these down. Those enzymes can't break down other things that they might need to. Then we have some other typical antidepressants. So things like tricyclic antidepressants. These often tend to elevate mood. So things like, like phenothiazine is an example here. And their mechanism of action is also something to take in mind as well. So the way these work is slightly different. So again, they're still increasing the availability of serotonin, norepinephrine, and dopamine in the synapse, but rather they're interfering with their reuptake. So they're not interfering like the previous example with their breakdown, but instead with their reuptake back into that axon terminal. So because they're not being taken back up, they're readily available to be used as well. So very similar effect, right? But a different method of achieving that. And then one of the downsides here is that they tend to not be effective in all patients, right? So this is more, we don't know exactly why, but some people are more, susceptible to these medications than others. Next, we have what you might be familiar with more commonly are selective reuptake inhibitors, or SSRIs. And we have a couple different types of these. We have just standard SSRI, which is actually selective serotonin reuptake inhibitor. And then we also have SSNRI, or selective serotonin and norepinephrine reuptake inhibitor. So this is, again, similarly acting to prevent the reuptake. You can see sort of in the example here, it doesn't take those neurotransmitters back up into the axon. Instead, they remain in that synapse, able to bind over and over again. So it increases that availability of serotonin and norepinephrine with that synapse so that it can bind over and over. These tend to be safer than some of those other, tricyclic examples, but they also, do seem to work for more people as well. So a common example here is something like Prozac, a pretty common, used pretty readily form of antidepressant. And then, of course, we mentioned this before, but electroconvulsive therapy is another form of treating antidepressants. So this is typically used for the treatment of very severe depression. It's often used in the conjunction with other medications as well, so not solely on its own, but it does tend to relieve the symptoms of depression pretty quickly. So some of those other medications, the downside to those is oftentimes they can take upwards of a couple of weeks before the patients even see benefits of those medications, whereas ECT acts very quickly. Even after that first session, normally you see improvements. That delayed response also of those medications is another reason why patients may struggle to see success with antidepressants. They may take them for a week, see no change or no improvement, and then decide to stop taking them because they haven't seen any improvement. When in reality, they would have needed to just take them for another week or two to actually have that effect be noticed in their behavior. All right, let's talk next about mood stabilizers. So we're coming up here. We're going to talk about mood stabilizers here, and then last end with some of the consequences of this treatment options. So mood stabilizers, we can think of things like lithium is a pretty common one. These are used to treat different bipolar disorders. They tend to be either safe or toxic. Really depends on kind of how they're administered, right? So sometimes if the blood levels aren't monitored, they can become toxic if in the wrong dosage. But if blood levels are monitored and the right dosage is used, they can be fairly safe to use. They tend to oftentimes show issues with noncompliance by patients. So that's because they treat both manic and depressive episodes and mood swings. So oftentimes people with bipolar disorder choose to not take their medication or not take things like lithium because they actually like those manic episodes, and so they don't want to have those reduced. Unfortunately, the way this medication works is it has to kind of work and reduce both of them. Oftentimes patients report sort of a more numb feeling, and so they risk those depressive episodes to achieve those manic episodes as well. So they'd rather have that than give up the manic episodes and take this medication. So we see issues with noncompliance quite often with this, where patients don't want to take this medication. Also really interesting here, the mechanism of action here is actually unknown. So the more we learn and the more we discover about these, the better we might be at using them or coming up with better alternatives here as well. So some examples of other mood stabilizers I'll just mention, things like valproic acid, carbamazepine, and lamotrigine. So these are just some other examples here of mood stabilizers aside from lithium, which is one of the more common. All right, lastly, let's talk about some of the consequences of pharmacotherapy. So this is, again, the use of medication to treat different psychological states or disorders. So we can see this graph here, and this is basically the average amount of participants that were in psychiatric hospitals over the years. So the more we've used these medications to treat different psychiatric disorders, the less we've seen patients need to be put in psychiatric hospitals, which on one hand is a very good thing. It means we are treating a lot of these issues and seeing less people put into these places where we just sort of have nowhere else to put them. And so this is a very fantastic piece of data. What's not so fantastic is the other side of this, is we also have seen an increased rate of imprisonment and homelessness with these people, with people with different psychological disorders. And so typically more mentally ill people tend to be jailed each year than are admitted to state mental hospitals. So while this graph shows the psychiatric hospital decrease, we don't see is the increase in incarceration rates. And also, about a third of every homeless person in the United States, at least, tends to suffer from some form of serious mental illness. So it's certainly still a problem that we need to continue to work to solve, but we have made some improvements if you look at it from that perspective. All right, and that wraps up chapter 8. I hope you guys have a great rest of your week. Next week, we are going to jump into, we are going to revisit the topic of alcohol. So I know we touched on alcohol in our depressants chapter, but we're going to come back to it and focus on it in more detail and talk about, again, just more of what it does and how it interacts with the body, because it's kind of a more common and known drug that is more prevalent in many people's lives.